insulin resistant among patients in Victoria Hospital, and also is taking part in RNTCP, the TB treatment programs at Ramaya Medical College previously. So I request Dr. Ramesh to give the lecture on HIV care.
Good afternoon. I thank Dr. Chandrasekhar to give me this lecture pre-lunch actually, which is most of people we are very much hungry. I think so.
Make them free.
Yeah. And also the hungry people is also, some people are angry, like why he is taking that this time, let him be allowed for the food or anything. The thing is, I actually replaced Dr. Narendra Prasad, who has gone to Geneva, and immediately I took this interesting topic. Basically, I was working as a RNTCP medical officer in Ramaya Medical College and KC General Hospital. By that time, I was seen around a few hundred cases of where TB people are suffering from HIV. That's why that made me to take this interesting topic. Mostly, like how people are getting hungry and they are getting angry, like most people who are suffering from HIV, they are 50% of people also suffering from pulmonary, that is respiratory diseases. Dr. Chandrasekhar requested me to talk about how to suspect HIV in a respiratory disease. Then I went and saw the literature. Recently even WHO has given the guidelines. Please do a HIV test for all inpatients. Then when I saw the literature, you should do all the respiratory cases for HIV test. Then I decided to talk about pulmonary complications of HIV that is commonly available. Then I decided no, it should be a very interesting topic, because lot of what we have seen in during clinical practice, that only I would like to tell in this lecture. Actually, 50% of this respiratory disorders is seen in this HIV cases. How does the HIV cause AIDS? That everybody knows, like HIV infects and destroys the important immune cells, and immune system when it is destroyed, it is very important about CD4 cells, that is cluster differentiation cells. And also for this HIV and AIDS, the best test to go for is HIV, that is plasma, HIV RNA test, and CD4 count. Other tests can be done along with this is, first is TRIDOT, which is especially we do, and ELISA test, then P24 antigen, that is HIV DO we call, P24 plus ELISA, and only confirmatory test is Western blot test. See, in this test also the WHO has given the guidelines, like as soon as the patient comes and his test became positive, you should not tell the patient you are suffering from HIV or anything. You have to have a confirmatory test, either one TRIDOT, one Western blot, or two ELISA tests from two different kits from two different companies. That is also holds good. Or CD4 count with plasma HIV RNA. In plasma HIV RNA also, sometimes if the viral copies is less than 5,000 copies per ml, it is very difficult to say that it is positive. If it is more than 5,000 viral copies in blood, then only we are able to detect this. Because I would like to share one of my patient experience. A patient was around 48, beautiful 48 years lady, came with a pyroxia of unknown origin, which is referred by a general practitioner to me. He already put it on a lot of antibiotics and he has referred to me. Then when I see the patient, it was like evening rise in temperature, cough was there, loss of appetite, loss of weight. Classically, like it looked like tuberculosis. When I saw his previous 10 days X-ray, it was like it was completely normal. Then I repeated the X-ray and sputum examination for AFB, and it became positive. When it became positive, I was an in-charge officer for RNTCP. I added category 1 RNTCP category 1 dots. The thing is, she didn't gain any weight after 1.5 months. There was fever was not gone for her, and she was as same when she has came 2 months. But the AFB was negative. Then it made me very much suspect. At that similar time, her husband has met with an accident. Like I referred to one of my close orthopedics doctor who did his dynamic hip screw treatment immediately. Then he told that the patient is fine and discharged. After like 2 months after everything, there was no weight gain, the fever is not gone, and the thing. Then I added ofloxacillin to that, suspecting some of the organ. But in that time also I didn't do any test. After she came after 6 months completing the treatment. Fever was all right. The patient was already okay, no problem. But there is no weight gain. The cough and everything was all right. X-ray does not show any picture. Suddenly after stopping treatment of 2 months back, she developed herpes zoster. That is a very huge herpes on her face. Then I was very surprised. Then I wanted to test for HIV because herpes zoster is not commonly seen like that. Then HIV was positive for her, 48 years old, and I was very much surprised. Immediately I called to the orthopedician who was operated for her husband. I told to my colleague that the patient wife is an HIV positive. I have done the test for that husband. He told I have not done. He told he had a prick on that operation. Then he became very nervous and he confirmed me more than 10 times, calling me that patient is HIV positive or what. Then suddenly he went for RNA viral copies immediately within 5 minutes, like he was very afraid of that. Then we searched the data where is the house of that patient. We went there and we took that husband and came and we did the HIV test. But surprisingly it is negative. Okay, this is how we are not able to suspect lot of cases like HIV. Then we have a counseling, because I was doing counseling for Asha Kirana in Mysore. We need a lot of patience to talk with the patient and repeatedly. First date only they won't tell anything. You have to repeatedly close to the patient and talk to them. And I got a data 10 years back. She had a major accident where she has been transferred for 10 bottles of blood in Davangere Medical College. Then that is the cause for her HIV. Then that time I suspected any patient who already known diagnosis like it's tuberculosis, there is no weight gain, there is no improvement in the fever, there is no appetite improvement or anything is there, you can suspect HIV. That is how where you can suspect, if your empirical treatment is not working properly, if your suspecting is not right, if it is carrying a longer time and it does not working properly on that patient, you should go for HIV test. Next. Actually, this slide is taken from the net. It is a very nice slide. It is a basic that how the HIV virus multiplies into virons and this thing. You can see that HIV viron and GP160 CD4 receptor get attached. Next slide. Uncoating of this thing will be there inside the viral RNase integrase reverse transcriptase will be released. Integrated core. Next slide. Reverse transcriptase, where newly created viral DNA is formed from the RNA by reverse transcriptase. This is NNRTI, NRTA, where the anti-HIV drugs act. And most of my topics is less burdened by Dr. Sujit Rajan, because only the adherence of the treatment is very important in HIV treatment, where these drugs act on it. Viral RNA. Next. Integration of the viral DNA, nucleus, cellular. Next slide. This proviral transcription. This is once again messenger RNA has come to ribosome is involved. Viral RNA is released. Next. And then ribosomes along with the polyprotein chain, it forms a new virons. Next. Complete cleavage into the particles. Here the protease inhibitor acts on this chain. Okay. Next. This internal code released virus infection particles, CD4 count. The patient should be treated. It is a very simple, because there are a lot of thing has come in HIV, because HIV and should be a separate subject, as it takes a lot of time to talk, because lot of drugs has come, new things has coming out in HIV, because in TB not even a single new drug is from 1964, but in HIV every second new drug, and cardiology every one-tenth of a second a new drug is coming out. That's why this HIV should be a speciality, like it should be open as a new course. Like I request, if Dr. Nagbhushan is there, I would request sir to open a new course for the post-graduation for HIV, which requires lot of effort to treat this. Now that is, I treat the patient according to if viral count, that is CD4 count less than 200 and more than 20,000 of viral copies is there. When should not treat the thing? If CD4 count is more than 350 and viral copies is less than 55,000, there is no need to treat. Okay, if patient is asymptomatic. If symptomatic or AIDS related patient is there, please treat everybody with HART, that is highly active antiretroviral treatment. That HART treatment is a multi-drug treatment. It contains one NNRTI, that is non-nucleoside transcriptase inhibitor, nucleoside inhibitor and protease inhibitor. How does HIV causes AIDS? AIDS, like CD4 directly coordinates with other cells to immune system battle the infection. When CD4 cells are destroyed in the body, loses ability to fight the infection, there will be opportunistic infection in the body. That opportunistic infection, an HIV patient gets an opportunistic infection is equal to AIDS. That is how it is, very simple. HIV plus this thing, opportunistic infection is equal to AIDS. Next slide. This is a data that is 2006. More than 95% are low and middle income countries. Almost 2,000 are children under 15 years of age. About 1,200. This is given by UNAIDS. Next. This is a 2006 estimation. I want to concentrate on only in this. People living with HIV. I don't know, because there are 39.5 million, or it is divided by 4. When I see regularly, when I see a lot of HIV patient, one patient which have come in Ramaya, he'll register over there as HIV, and the same nodal officer gives the data over there. The same patient after 2 or 3 months will go to another center, because they won't be happy with those centers. They go there also. They repeatedly register over there, and I am seeing that a lot of NGOs are repeatedly registering the same patient for more than 2-3 times, and I don't know, patient living with his HIV is more by false data in our India. I don't know about abroad, but new infection, you are really, I don't know. Death is too, because death is only registered in register book. I don't think it is multiplier or anything is there. Next. There are 13.2 million children who are orphaned due to this epidemic. Next. HIV presentation, that is primary HIV, asymptomatic screening, chronic HIV, and late stage AIDS. Like primary HIV is lymphadenopathy, is previously everybody knows. Now my topic is only about to talk about HIV and lungs. Like I don't want to go deep into the subject, and I think everybody is hungry. The thing is evaluation. What is commonly seen in respiratory disease? A patient only complains cough, breathlessness, pleuritic chest pain. By these 3 things you have to evaluate. See, you should know the complication of the pulmonary complication of HIV. That is infective cause, non-infective cause. Next. This is where are the HIV, this thing, opportunistic infection in brain, toxoplasma, that cryptococcal meningitis. That cryptococcal meningitis, a person who is having a dyspnea, a known HIV patient who is having dyspnea along with headache, we can suspect cryptococcal meningitis. Eyes, that is CME retinitis. CME retinitis can also cause diarrhea and also retinitis in the eye, and also sometimes lower respiratory tract infection. This candidiasis is universal. Then lung, commonly that pneumocystic carinii pneumonia. Now that pneumocystic carinii they have taken out, they are calling as pneumocystic Jackarowi. The new term has been named by carinii, has been replaced by Jackarowi. Next, herpes, that is herpes simplex, herpes zoster shingles, the genital herpes HPV. Next slide. this is a old slide only. Like you can see when CD4 count is 400, you can see tuberculosis. See, talking about tuberculosis can present in both forms, like acute forms and late stage. Depending on CD4 count, you can classify according to X-ray and the presentation. If the CD4 count is more than 400 or near 400, the patient presents as classical tuberculosis, right upper lobe cavitation, sputum positivity, weight loss, the treatment response will be very nice. And the other thing, if the CD4 count is less than 200, you can see other types like disseminated form, multiple adenopathy, and the patient does not have involve of the right upper lobe or upper lobe, it will be only a lower lobe involvement. This will be changed if depending on the CD4 count. I don't know, because it is due to the immunological reaction. I think this answer will be better given by Dr. Chandrasekhar because of the immunological part involved over there. The second is when you suspect TB, the patient don't suddenly go into to start treat for the antiretroviral treatment. Most of time we have seen while treating tuberculosis itself, there is the thing, the CD4 automatically triples or fourbles. Like a patient who is having 250 or 200, when you start with normal, there is no extraordinary, any drug should be added over there or anything. Normal DOTS is enough. DOTS therapy is enough. That is to be followed is category 1. All 4 drugs should be added. You can see the improvement. There will be increased CD4 count. After that, you can refer to the HIV specialist. Okay. Next. The same thing, when you can suspect, you can oral thrush, hairy leukopenia, tuberculosis, you can get around CD4 count. When it is come to the end, like you can see the atypical tuberculosis like mycobacterium, AVM complex diseases. That is commonly causes a lot of these glands, the scrophaloderma, or it can cause diarrhea also. Cytomegaly, that is eye, cryptococcus, meningitis, herpes, toxoplasma. As the counts decreases, the invasive part of the bacteria goes on increasing. Next slide. When there is acute retroviral syndrome, you can see I am concentrating only on lungs, that is pharyngitis, cough. Most of people who is having a HIV will be coughing around, 60 to 70% will be coughing around. Fever will be for 96% in the acute retroviral syndrome. Next slide. Next. In acute HIV infection, symptoms present day to weeks after initial. It is just like a viral infection. When it is an acute HIV infection, it is just like a viral infection, fever, fatigue, headache and rash. It can't be differentiated in any other viral infection. There will be non-specific symptoms overlap the common viral infection. Next. Rashes are around 40 to 80%. Next, you should differentiate it with infectious mononucleosis. HIV associated pulmonary disease infective cause. This is very important because when you are talking about HIV and lung, I concentrate on each and individual. Upper respiratory tract commonly is by Streptococcus pneumoniae, H. influenza, or the common organism you can find, or Staphylococcus. Sometimes you can see the upper respiratory tract infection. Acute bronchitis, after following upper respiratory tract infection, the patient is not treated well, you go for acute bronchitis. The thing is here, the HIV people are more prone to get respiratory disease. In that, the smoker is HIV positive is more prone compared to non-smoker. That is also very important. You should ask the history very well, counsel them, smoking history. Along with this, they will have a lot of symptoms like this: upper respiratory tract infection, acute bronchitis, and bacterial pneumonia. That is Staphylococcal pneumonia is the commonest one. That is the commonly seen in this HIV patient. PCV, I told PCP Kerani has been changed to PCP Jerosi pneumonia recently. This PCP, how we have to suspect? Like if it is acute bacterial infection, the fever will be only for 2 to 3 days or 2 to 4 days. If the breathlessness, fever or dyspnea continuing for 2 weeks to 4 weeks, please suspect PCP. PCP also, if you have a saturation, if saturation is more than 96, it is mild. If it is between 91 to 96, it is moderate. If it is less than 91, it is severe. But you should not put an empirical treatment in all these things. You should prove what you are doing. Like when you are suspecting a PCP, you should prove. How can you prove that? The ball, that is bronchoalveolar lavage, if you take, it is around 85%, it is okay. It will be true. Along with, if you take transbronchial biopsy, it is also 87. When the two are combined together, 99 to 100% you can diagnose PCP pneumonia. That is the diagnostic. Don't put empirical treatment, because until you diagnose it, you will be leading to lot of antiretroviral treatment with this empirical treatment. These drug interaction causes lot of other multi-drug resistant and multi-drug resistant problem. And fungal infection, commonly when you should think about the endemic area, the people who are coming in the histoplasma region like US or anything, you should suspect about histoplasma, other things, blastomycosis, other things. This MTB I have spoken briefly about you. Next. And Kaposi sarcoma, I have not seen a single case. Lymphoma, I have seen one or two. That is non-Hodgkin's lymphoma is very commonly seen. Bronchogenic carcinoma, then non-specific interstitial pneumonitis or lymphocytic pneumonitis, you can treat this by steroid. Next. These are the tests. Already I told you the serum antibody test. Now even saliva and urine antibody test for ELISA can be done. Rapid test like others, P24, HIV, DO, Western blot, confirmatory test, HIV, plasma RNA can be done. Next. And you should, when counseling also, you should counsel the partners how they have sexual practice, past STDs, pregnancy history, protection from STDs. That is, you should remember 5 Ps always when you are dealing with an HIV patient. Next. You should have a good vision to see all these things. Next. Chronic HIV presentation, that is mostly clinically latent septal clues. Next. Because when you have respiratory symptoms, along with that you can see a lot of dermatological things. There will be molluscum contagion, candidiasis. When you suspect these things, please do HIV test. Next. Even diarrhea, that is chronic diarrhea. This is hairy leukoplakia. Next. You can see erythematous. There are two types, like this is pseudomembranous type is white patch, this is red patch. Next. Dermatological clues, infection, bacterial, fungal, viral. If you suspect any of these along with that, inflammatory, that is psoriasis, seborrheic dermatitis also, you can go for the clues. Don't think about age is the only criteria for the diagnosing HIV test or send for the HIV thing, because Dr. Chandrasekhar has seen the age of a lady 70 years old is suffering from HIV. With this psoriatic arthritis, she came with that. Doctor suspected that thing because of multiple joint involvement, and she was HIV positive. And in the same month, we got another 2 cases who are more than 60 years old. Next. Laboratory clues, you should think about other thing when you have anemia, ITP, leukopenia, hyperglobulinemia, false positive reaction like ANA, elevated PTT, decreased cholesterol, renal insufficiency, proteinuria, you can suspect and you can go for HIV testing. Next. Late stage presentation, usually clinically obvious, should not be missed. Opportunistic infection predominates. That diarrhea, candidiasis, other things will be very much. Wasting is very common. Next. Like treatment, I don't want to go too deep into the treatment. Adherence, like Dr. Sujit Rajan has told, adherence to the treatment is very, very important. That you have to always add multi-drug. You don't add a single drug, 1 NNRTI, 2 NRTI and PPI. If commonly what we are using basically stuvadin, limivudin and this effervescence, that is more than efficient, but the patient should take continuously. According to latest studies, the new treatment or the old treatment, if it is with a good combination, the patient having a good adherence, the treatment is good, 80% it will be okay. If patient misses the drug, does not take, he stops, and if he retakes, there will be multiple problem and multi-drug resistance will be evaluated. That's why the old treatment is more than enough. You can continue with the same treatment. If you suspect of any MD or anything, you can refer to the HIV specialist. Next. Thank you very much. I briefly covered this topic. Thank you very much.
Thank you. Very nicely told about HIV infections. And he has specifically stressed how doctors become susceptible to this, how you should suspect, how you should protect yourself. You must take care, because doctor in a hurry to do surgeries, they are very very much amenable to HIV infections. When the lady had the HIV positive, husband did not have, it leads to suspicion. So he traced back to history, and blood transfusion was this very nice job you have done, because in Hindu society, if one is having, if husband is having, it is okay, but if the lady is having, husband does not have HIV, it leads on to many complications. So Dr. Ramesh has taken wonderful care. Very nicely, we must thank him actually, and it is because of blood transfusion. And there are so many other things that how the mode it spreads. That is another important is artificial insemination. The person may not have gone to other things, but artificial insemination, if there are no issues earlier, this has to be taken. And history of hemophilias who are going for blood transfusions off and on, you have to check that. And organ transplantation, this is very, very important. Many a time organ transplant, nowadays it has all been made rule-wise that you have to check all for this. And IV drug users, IV drug addicts, he may be a fellow from a posh family, he may be brought in a 50 lakhs rupees car, but he may be suffering from HIV infection because he may be addicted to certain drugs, self-using the syringes. IV drug users. And the statistics you gave, I'm very happy that is nearing to the statistics I was called to give a lecture 1 week ago. It is 32 million adults in 2000, WHO report. 32 million were positive, not suffering. HIV, AIDS is a full-blown picture. And 1.2 million children have become positive HIV in 2000, a WHO report. And in India, 5 million HIV positive, but really it's less number of cases. And another important thing is, he told that I would like to stress as a physician, I had a case just recently, just 2 months ago. He is a 68-year-old fellow who came to me with history of loss of weight. Then when I looked at his legs, he had skin lesions. Because we are physicians, he tells, he did not tell, sir, I have shown it to skin doctor. Where you have shown? I have moved. He has shown to all high-tech hospitals in Bangalore city, almost all. But all of them have given, because he is a diabetic fellow, either a steroid ointment or an antibiotic ointment, 3 to 4 months skin lesions. He has not improved. They have brought to me because he was losing weight. So any unexplained loss of weight, we subjected for HIV, it was strongly positive. Then I phoned to the dermatologist who had treated him that it is so and so, you should not miss like this. They coolly accepted that he is a military. Then why he suspected he was an ex-military man. So all military fellows are not like that, but it is not explaining. Unexplained loss of weight, unexplained diarrhea, unexplained fevers, PUOs. You must always suspect, you subject him for a test. And our people, many a time they do, when you write HIV test, he may not come to you again because they know what is HIV. Even a layman knows HIV ಅಂತ ಕಣ ಇದ್ಯಾಕೆ ಸರ್ ಇದನ್ನು ಬರ್ದಿದ್ದೀರ HIV ನಾನೇನು ಅಂತವನಲ್ಲ ಅಂತಾನೆ. ನಾನೇನು ಅಂತವನಲ್ಲ ಅಂದ್ರೆ ಅವನು ಅಂತವನೇ ಅಂತಲೇ ತಿಳ್ಕೊಬೇಕು. Because if he is really not that fellow, yes sir, I will go for a test because of. So like that, our people when we write HIV testing some 6 years ago, you will come now with that because he has avoided the test. So please see that the tests are done. And thank you, doctor. And that fellow, nicely we have put 3 drugs to him. He is very nicely responding. It is inhibits the viruses. Of course, Dr. Chandrasekhar knows more about it. The second case I am treating, these are 3 drugs, triamine drugs, all that zidovudine. Very nicely they are responding. But one thing is costly. And one information in KIMS hospital, they have, along with the AIDS Prevention Society, we have opened a microbiology center where we are planning to give free drugs. Already in government boarding hospital it is there, but in some centers along with the aid of AIDS Society, they are giving free drugs. And CD4 count, when you refer, they charge 5,000, 6,000, 10,000. And here we will be doing some 300 rupees they are doing. So if you got any case like that, very poor fellow, either sent to boarding or even in KIMS we do for 10 rupees they are doing 3 tests, kits. When once HIV becomes positive, immediately we should not label him. They do the 3 tests from 3 different kits. Then you can send it for Western blot test or so for further confirmation. So with this, thank you all. I thank the organization for Dr. Chandrasekhar and team for having invited me, and I thank all of you. Thank you, doctor.
We thank Dr.